Hello everyone, my name is Frédéric Michard and I'm from Lausanne in Switzerland. And so before I start, I'd like to briefly disclose the fact that I'm today leading a consulting and research company, MICO, based in the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. So why discussing postoperative hypertension? Having in mind the large number of recent studies focusing on what's happening during surgery. I think it's very important to realize that if in the OR, in the PACU, in the ICU, we monitor blood pressure very closely, the situation is completely different as soon as patients move to the wards. Indeed, on the wards, nurses are usually doing a spot check of vital signs only every 4 to 8 hours. And we know from recent studies that because of the intermittent nature of this spot check, they may miss a significant number of adverse events, and for instance, of hypertensive events. In this study published last year by the team of Dan Sessler from the Cleveland Clinic, they showed that when nurses were spot checking blood pressure every 4 hours after surgery, they actually missed almost 50% of hypertensive events. This is another and more recent study coming from the UK, where they also monitored blindly blood pressure continuously on the wards during the 12 hours following surgery. And then realized that 54% of patients who are part of the study experienced at least one episode of hypertension. And it would have been only 5% if they were simply looking at intermittent measurements. In addition, these studies showed that a mean of 81 minutes of hypertension was missed just by usual monitoring, again, because of the intermittent nature of the spot check. If we look back at the POISE-2 study, which is, as you know, a renowned New England Journal of Medicine publication from 2014, you may remember over 10,000 patients undergoing non-cardiac surgery from over 130 hospitals and 23 countries. One of the findings reported in the paper is the following. The median duration of hypertension during surgery was 15 minutes, and it was 115 minutes the day following surgery, so 10 times more. So clearly, postoperative hypertension is common, often prolonged, and may remain undetected for hours. In addition, it is strongly associated with complications, with postoperative complications. This slide was built from a paper published by Dan Sessler in Anesthesiology a few years ago, where he showed a very significant association between intraoperative hypertension and postoperative myocardial infarction and death, with an odds ratio of 1.08. He also showed a significant association between postoperative hypertension the day of surgery, when patients spend hours in the PACU, and myocardial infarction and death. But I think the most interesting result was the following: the very impressive association between postoperative hypertension between day 1 and day 4, that is to say when most patients are on the wards, and postoperative myocardial infarction and death. So there is here a paradox. We monitor today very closely blood pressure during surgery and right after surgery in the PACU, but this is not the case in the wards. Another very interesting and recent study from anesthesiology, a large number of non-cardiac surgical patients. And the authors looked for an association, a possible association between postoperative hypertension and postoperative myocardial injury. And as you can see on the right-hand side of the slide, they observed a very significant association, whatever the definition used for hypertension and whatever the duration of hypertension. What was interesting as well in this study is the fact that they did not observe any association between intraoperative hypertension and postoperative myocardial injury after adjusting for postoperative blood pressure. And that's something important to keep in mind, that clearly what's happening during and after surgery is often linked. And as a matter of fact, they nicely explain in the discussion that both in the VISION and the POISE-2 trials, the association of intraoperative hypertension and myocardial injury was no longer statistically significant after adjusting for postoperative hypertension. Another reason to consider close monitoring of blood pressure after surgery on the wards is the following. When patients develop very severe adverse events, such as cardiac arrest or the need for ICU admission, or of course death, very often they actually deteriorate progressively. And so if we are looking more closely at vital signs, we will probably be able to detect clinical deterioration at an earlier stage than we do today. And so in this large study from Australia, New Zealand, and the UK, they looked at abnormalities observed between 15 minutes up to 24 hours before the serious adverse event was observed. And as you can see on the slide, actually, the most common abnormality detected was systemic hypotension. So another reason to monitor blood pressure more closely than we do today on hospital wards. So we need to improve the way we monitor blood pressure on the wards, and to do so, actually, there are already a few existing solutions. Clearly, what we need are non-invasive techniques enabling continuous monitoring of blood pressure. And you possibly know that there are actually different techniques enabling continuous and non-invasive blood pressure monitoring today. You possibly recognize volume clamp techniques. You may use them during surgery. They have been designed to be used in the OR, but not for the wards. As you know, they are a bit too bulky and expensive to be used in ward patients. They're also not comfortable enough for awake patients. And in this UK study I already showed you a few minutes ago, actually the volume clamp technique was tolerated by only 39% of patients up to 12 hours following surgery. Also, they are not wireless techniques. Having said that, if you have a volume clamp method, it might be very useful if you use it on your crash cart when patients deteriorate, to understand what are the underlying mechanism of hypertension. Because as you know, these volume clamp systems also integrate a pulse control algorithm. And so you have not only blood pressure, but also information about blood flow, cardiac output, and an estimation of vascular resistance. So this is what the team of Rinaldo Bellomo did in this study. They used the volume clamp technique as part of their emergency cart. And in this study, they looked at the intervention from the rapid response team when they were called because of hemodynamic instability, hypertension on the ward. So first of all, most of the time, the rapid response team was giving fluid. And they were monitoring at the same time blindly cardiac output and vascular resistance, and actually realized that 91% of the time in these patients who were developing hypertension, the cardiac output was normal or high, suggesting that most of the time hypertension was not related to hypovolemia. The same kind of results have been published by this UK team again. They used again a volume clamp technique, which is very convenient for research on the wards, to demonstrate that actually when patients develop hypertension, a significant proportion of these hypertensive events are actually are related to vasodilation because they observed or they're associated with a significant decrease in vascular resistance. But to monitor continuously blood pressure on the wards, we need small devices, affordable because we are going to monitor a large number of patients, comfortable enough to be forgotten by patients who are wearing them. They also need to be wireless because we expect our patients to leave their bed. As we all know, early mobilization is a key element of enhanced recovery programs. In addition, hypertension is actually very common when patients leave their bed. So we need a monitoring system able to follow patients when they leave their bed or even their room, for instance, for physiotherapy. So what could be convenient is to use a new pulse decomposition method. You may have heard about it. It's a system applying a constant and low pressure around your finger, around 40 millimeters of mercury, so you basically don't feel it. It's a wireless system, pretty light, really convenient to be used on the wards. To be honest, there are not so many validation studies published so far, but this is one showing a pretty fair agreement with invasive blood pressure measurements in the OR. And you have the opportunity to combine additional sensors to monitor pulse rate, SpO2, respiratory rate, and temperature. And so opening the door to the continuous monitoring of early warning scores on the wards. Applanation tonometry has been proposed as well for continuous monitoring of blood pressure. This is not a new concept. And actually, I'm not aware of any commercially available system today available, still available in Western Europe and in the US at least. What is available is the pulse wave transit time method. So you probably know what it is. The pulse wave transit time is the time difference between the cardiac contraction and the arrival of the peripheral pulse. So if you monitor simultaneously ECG and pulse oximetry waveform, you can estimate the pulse wave transit time, and there are equations enabling the estimation of blood pressure from the pulse wave transit time. And so you may have seen this paper published a few years ago in Anesthesia and Analgesia from Dr. Kim from Seoul in South Korea. They nicely showed that they were able to use, or it's possible to track changes in blood pressure during anesthesia induction just by actually computing changes in pulse wave transit time. Having said that, I'm not aware of any solution today available in the OR to track blood pressure continuously from the pulse wave transit time. But there is, as a matter of fact, a system, a monitoring system, which has been specifically designed for the wards, which is using this principle. So you have electrodes to record the ECG, you have a pulse oximeter on the thumb, and so the system is going to continuously compute pulse wave transit time, detect changes in blood pressure, and you also have a wireless brachial cuff that can be used to calibrate the blood pressure measurements from time to time. What are the solutions for the future? First of all, applanation tonometry has been miniaturized, and this is an example of a micro-electromechanical system that is part of a small bracelet. And you see here the example of a comparison with invasive radial measurements. Volume clamp methods were also recently miniaturized. This is a study actually now in press in Nature Communication, suggesting that we could use simply a ring in the future to monitor blood pressure in ambulatory patients. And this is the example they published, where you see in dark blue the volume clamp measurements, which is used as a reference in this study. And in soft blue, you have the measurements, simultaneous measurements obtained from this new ring concept. So obviously very promising. Pulse oximetry. We could even envision to use pulse oximetry, if not to measure blood pressure, at least to detect changes in blood pressure. And this is what has been done by Yacine Gamri from the team of Patrick Schottker from the University of Hospital of Lausanne. They used a machine learning approach. And so they fed their machine learning algorithm with a large number of pulse oximetry waveforms and corresponding invasive blood pressure measurements. So the algorithm was able to learn how to recognize specific patterns or specific phenotypes, which are characteristic of a change, a decrease, or an increase in blood pressure. Then they tested the ability of the algorithm to detect a rise or a drop in blood pressure during anesthesia induction or during tracheal intubation. And you can see on the left-hand side of the slide, the systolic pressure changes, on the right-hand side, the mean arterial pressure changes. And you can see the algorithm was able, just looking at the pulse oximetry waveform, once again, to track pretty accurately changes in blood pressure. Thanks to flexible and stretchable electronics, we can even envision to use in the future ultrasonic and piezoelectric sensors. This is an example of an ultrasound patch. It is not designed, of course, to be positioned on the joint, but it's just to show you what it looks like. That's something you would put on the carotid artery, on the brachial artery, on the radial artery, for example. And this is a piezoelectric sensor, wireless as well, enabling pretty good quality, almost high fidelity blood pressure waveforms. You can easily imagine these sensors would be extremely useful to monitor blood pressure in ambulatory patients. Video monitoring might be an option as well. The concept is to turn cameras into health monitors. And you may have seen some of these systems already able to compute or estimate pulse rate. And respiratory rate from video recordings. This is a prototype designed to estimate SpO2, oxygen saturation, just looking at your face. And you may have heard about this new system predicting blood pressure from video recordings. So there's actually a publication, a validation study published in Circulation about this transdermal optical imaging technology. And this is a correlation they reported between the reference systolic blood pressure measurements on the x-axis and the predicted systolic pressure from video recording on the y-axis. So obviously the relationship is significant from a statistical standpoint, but I think it's pretty weak. And as you can see, I mean, these were normal systolic pressure values between 100 and 140. The study was done in healthy volunteers, and so we have actually no idea if it would work in patients with a low or high blood pressure, but it's just to show you that there is a lot of research going on in this field, and we'll probably have many different technological options in the future to upgrade the way we monitor blood pressure on the wards. So in conclusion, postoperative hypertension is common, prolonged, and often goes undetected because of the intermittent nature of blood pressure spot check. Postoperative hypertension is strongly associated with complications, much more than intraoperative hypertension, and it's probably because it may last for hours before we detect hypertension and react, which is obviously not the case in the OR. Volume clamp methods are not designed for the wards, but they could be useful if you have one of them on your crash card to understand the underlying mechanism of hypertension once patients deteriorate. The new pulse decomposition technique and pulse wave transit time methods are actually the only solution available today for continuous monitoring of blood pressure non-invasively. But clearly, we need studies to investigate, to further investigate the potential value of these technologies to, first of all, detect at an early stage hypertensive events and see if it may have an impact on management and postoperative outcome. And as you understood, many other techniques are currently under development, so that we should be able in the future, in the near future, to use many different techniques for monitoring blood pressure on the wards. If you are interested in the topic, I invite you to read this editorial published with Thomas Sheeran and Bernd Sogol a few months ago in the British Journal of Anesthesia. And with that, I thank you very much for your attention.